Hello, everybody. Welcome to the webinar series. My name is Matthew Klinsky, and I want to extend a warm welcome to everybody who's able to join us live today. This is our webinar series called Simplifying the Business of Medicine. And today we have a very good topic to talk about that I'm sure most of you are very excited about hearing, because it is on the topic of our thoughts and our minds almost every day, which is physician compensation. And today we have our co-host Gene Good, who's the CEO of Doctors Management, here to bring his expertise into how physician compensation can be structured, should be structured, and the thoughts around, what goes into structuring a compensation for hired physicians, for owner physicians in that practice, private practice space. So love to introduce Gene. If you don't mind, give a little introduction about yourself.
Matt, thank you. And it's a privilege to be here today. It's my goal that every attendee, that you guys find value in this session. It is for 20 years been working for physicians, and I find it a very fulfilling calling to help medical groups succeed. We're in some exciting times, some transitory times, and hopefully you guys find this compensation topic and how to align with those times helpful for your groups.
Perfect. All right, without further ado, let's jump into our webinar series, and I'll pass it back to you, Gene.
Absolutely. Okay, well, so again, we're talking about designing sustainable compensation models in practices. Again, that's myself, a very nice picture. It's real life, but okay, who is this for? So I was, and it was just so honored to see the amount of people who registered for this conference. And one of the things that from some of the registrations, I did want to make this very clear. This is really for stakeholders in private practice. We definitely do this in health systems as well, but it's really an entirely different mechanism and approach inside a health system. So I just want to have this up front, that who this is for is stakeholders in private practice. Health systems would be a different topic on it. All right, and then one thing, what's the situation in medical practices? Like, why is compensation, and why are there so many challenges related to compensation hurdles? And I really think the underlying issue is, over the last 20 years, we've seen the cost of living increase by 60%. We've seen the Medicare physician pro fee decline by 15%. So that means what the revenue was in a medical practice 20 years ago is 50% less than what it is today. And we'll get into how that breaks down into doctors who joined and started medical groups 20 years ago, really how they could just hang a shingle, be their own boss, and and just be able to see their patients and produce an income, and that work very well. Now, the economic realities, it definitely feels like you either need to be out of network with insurance companies or have additional resources than just one doctor generating income for a medical group to be viable. And we'll get more into that. So our agenda today: choosing your practice model, then aligning the compensation with the practice model, talking through details of the models, and then lastly, really talking through now where groups, it's almost become as important for getting the owner physicians and employed physicians, employed providers compensation, as well as the administrators of the group getting those compensation mechanisms aligned well. All right, so define your vision, core practice models. Right, so I would say 20 years ago when I started in this, 9 out of 10 medical groups had been or were at that time self-employed. And that really was, you had your own business for yourself or your own job where you knew your boss well. Nowadays, that has turned into the blended, which is at the bottom. Without really strategic thought, it just became out of necessity. Like, hey, margins are tight. We need to add we need to add a advanced practice provider, or we need to add an ancillary because margins keep on dwindling. We need to see more patients. It really kind of happened out of necessity rather than strategic, but the compensation models didn't follow. So the second bullet point, and this is one thing that we've seen some really awesome success with, is taking where medical doctors are taking the approach, hey, I am going to be a business owner. I'm going to build a practice that meets the needs of our communities. So while we have seen those reimbursements have a 50% essential decrease in revenue value, there has been such a growth in population, such a growth in demand, that we very much are seeing groups really do very well and thrive when they take the business owner approach. But it is a lot of change with that. So again, the kind of the two primary are, hey, we're self-employed, I'm going to have my own patient panel, or second, I want to be a business owner where I'm really trying to find out, identify what the need in my community is for my services or related services, unmet needs and related services, so I can go meet those needs versus looking at what your individual capacity is. And we'll get more into that in a little bit. But those are the kind of the two functional models. And I think the biggest question is, hey, do you want to be your own boss or do you want to own a business? They are different. And I think that sometimes that difference isn't recognized. All right, the self-employed model. You're the primary revenue generator. Like if we have $1 million in practice revenue, you're generating $800,000 of it. So therefore, the staff is primarily supporting you in generating revenue. Or here, the owner doctor is the primary revenue generator, and the staff is functionally supporting that individual doctor. There's a few ancillaries that really tied directly to the work that the primary doctor does. So this, if we take, a imaging in a surgical practice is a great example, like having the pre-surgical workups. It is an ancillary, but it's very much a part of that doctor's care plan for those. So that's and then really this question is, hey, do you want all patient care running through you? Another way to ask that question, are you comfortable with overseeing care provided by others, where it doesn't necessarily touch you, but you would oversee it? So you're one step removed from the care. The own your own business model. And again, this is just, again, functionally from what the environment is, this is the model that's growing very rapidly. I would say of our established clients, we're more and more the owners of the group are generating less than half the revenue. We have a couple scenarios where owners are generating less than 20 to less than 10% of the revenue. So they are very much business owners, and the success of the business is much more dependent upon how they lead than the work that they do and than individual patients they treat. And we'll get into some more of that too. Again, so you have this model, it's employed providers. So there's elements and additional resources that are necessary to have employed providers or ancillary that generate most of the practice revenue. So you have staff that plays a support role to the physician owner, staff that's playing a support role to those employed providers, and really thinking through, are we being strategic on how we are setting all that up? And again, this really comes down to you are dependent upon the community needing the service. Your communities, if you have some satellite offices with there, and even having elements for how are you tracking and monitoring what the community need is, or what are unmet community needs and related services. Just so again, sometimes that can create some protection for a medical group, depending on what's going on. All right, so then aligning compensation with practice vision. This topic is really short, but it's so important. We work with a little bit over 800 medical groups. I've yet to see a medical group that had what's on this slide, written on paper, except for groups that we personally work with. It's, hey, let's state our practice vision. Are we going to be a ENT group that's going to meet the needs of monitoring and meeting all the ENT needs in a community? Are we going to be a primary care group that's trying to meet all the unmet needs in a particular geographic area to have high concentration, or am I just trying to fill my individual patient panel? And then and those are that is a very, very different way to have a compensation model that fits. If hey, I'm just trying to fill my patient panel versus I'm trying to meet the needs in a particular area and then continue to grow and meet needs in other areas. Very different visions. Highly recommend clearly stating what those are. Then the second step is we want to identify how does the compensation model that we choose promote the vision. That can change over time, but it's a great way to go through that exercise to say, okay, hey, do we have alignment here? And then the third point, especially if you chose to do the business owner route, there needs to be a clear distinction for compensation for the physicians, for the compensation for work that they do as an employee of the group, and earnings and remuneration for being an owner of the business. Those are two different hats. We got one hat's a blue hat and one hat's a red hat. It's like earnings from both of those hats.
Yeah. EG, before we go
Mhm.
on to this, I think this is such a great component of the vision of the practice. I was always told when when I was running businesses in the past is if you have a 5-year vision or a 10-year vision, the smaller 6-month decisions become so much easier to make once you have that vision, that longer term vision in place. And I think having those vision statements, like you mentioned, really help the owners and the practice administrators really be in line on the bigger decisions, which makes those shorter decisions even easier. Would you agree with that?
Oh yeah, yeah, 100%. I mean, another topic we could get into is having some type of mechanism that you're using to run your practice, whether it's EOS and the Gino
Right.
Wickman
Yeah.
tractions is very popular, or getting down to okay, hey, we're just going to have 10-year, 3-year, 1-year
Right.
targets, and just figuring out what those are. But very like again, this is yeah. I mean, if we're not if we don't know what our endpoint is or what
Right.
success looks like you play to me you define the practice vision very similar to why if you're we were just mentioning basketball before we started, right? If you go out and play like a pickup basketball game like with your boys or friends like and you're just shooting around,
Yep.
the competition levels may be here.
Yep.
As soon as you start to keep score, it just raises the competition level. It just puts more intentionality behind every movement in a pickup basketball game. Well,
Yeah.
how much more when we do that if
Yep.
professionally? And
Yeah. You
okay, let's really define what we're going for.
tighten those sneakers and you start stretching a little bit more, right? You start really honing in on what you can do. So I love it.
You make it a
Okay.
little bit more physical, a little more, a little bit more body on somebody when you're driving to the basket. Yeah. So,
Yeah. So
um,
perfect.
and this is and this was your quote, man. I just thought this was so good. Compensation is not an HR issue; it's a business strategy. If we're modifying compensation all based on the feelings of a provider in our group,
Yep.
we've that's an indicator we may have lost our way from what the
Yep.
ultimate vision was. I thought it was such a great one, Matt. Thank you for that. All right, so the compensation models that are out here, we really again, there's two real high level approaches we take, and then we get into a lot of different nuances on blending them together. So the first is an eat what you treat model. Again, this is where most groups have started from because 20 years ago they were, hey, I'm just going to get my patient panel full. I'm going to be my own boss. So the eat what you treat really fits that extremely well. As you get more into this, if you go the idea of I want to be a business owner, I want to meet the needs of communities, I want to be always monitoring, maybe expanding to different communities to meet needs, with then going to a community-based model where there's really those two hats that I mentioned. Hey, there needs to be earnings from being an employee of the group, and there needs to be earnings from being an owner of the group. Really comes into play. And then the last is really a blend of those two. So the first model is really hey, there's very little need to have any type of compensation distinction between your work as an employee or your
Right.
ownership, because you're your own boss, you're managing yourself. That doesn't take too much time. If you're getting into a lot of arguments with yourself, well, that's a little different. Where when you're building a business and you have you have staff that's just not supporting you, but having, they're supporting ancillary providers, you have these employee providers that are generating revenue. That's where this community-based model and really having a distinction between, okay, what am I earning from being an owner of this, because it's taking time to do that, and what am I earning for being a physician in the group, and is it fair market value, becomes very important. All right, on the eat what you treat model, I was even having a discussion about this early with an ophthalmology group. It really comes down to revenue and expense attribution first, who's responsible for it, and then allocation. So if we don't know who's responsible for it, well, we definitely can't allocate it. And we'll get into this, but there's essentially three ways to allocate it. You can allocate it directly to a particular doctor. You can allocate it, hey, we're all going to share it equally. So if there's two of us and we have 100, and we had $100 or we had a $50 meal, each of us, we're splitting it equally. Well, it's $25. If it's direct, we're asking for two separate checks. And then if it's pro rata, we're doing it, who got the bigger entree, you're gonna pay a larger share of it, right? So those are the kind of the three functional areas there. The community-based model, and this is one where I feel like most groups miss this first bullet point. They don't have real intentionality behind, hey,
Right.
What is fair market value for the work that I do? How are we going to How are we going to calculate that? How are we going to agree upon that, so that we determine fair market value for work that we do? And then, are there specific expenses that we want to give individual owners autonomy over? And this point, Matt, came from me. I thought this was so good. Focus on contribution margin, not emotion. To me, one of the biggest disservices we've done in just our American society is having this term net worth. Our worth is not determined based off how much money we make. On a contribution margin, this purely comes down to, hey, if we have $10 come in, we can't spend 11 and be a sustainable business. So if we have $1 million come in, we can't spend $1,000,001 and have a sustainable business. It all comes down to, hey, revenue comes in, expenses go out. At some point, there needs to be a little bit more revenue and a little less expense for us to continue being in business. We can't tax people, and so that's where that contribution margin comes. It's so good to have that. And then the reason why to write this stuff down, hey, this is our vision, this is going to be our comp model, these are the expenses that we're going to allow people to have personal autonomy over. You write that stuff down so you have a guardrail. Like there will always be creep. There's always erosion. If we're not intentional, we do not go to our highest and best. We always go to the sedentary side of things. So there's some really good points on aligning pay with economics. If you're on an eat what you treat model, you really need to be mindful of the portion of revenue generated by owners compared to non-owners. The eat what you treat model really begins to break down if the owners are not producing substantially all of the revenue. Also, the eat what you treat model, it's really clunky if you have anything but equal ownership. Like if you want to, and really what we're seeing now is groups are trying to be a little bit more flexible. Somebody may want to be a partner, but not have to write a really big check in. So they want to have like a smaller partnership interest, things like that, where the eat what you treat models, they don't fit that. Also, owners having a different desire for the amount of time they work. If that's different, again, eat what you treat really begins to kind of fall apart of that. Again, what I mentioned earlier, we have kind of three expense categories. And if we were going to have a workshop in a few weeks, if you want to join a workshop, we would be able to kind of go through your particular practice and break down, hey, what would be in equally shared, what would be in pro rata, what would be in direct. Different ways to look at those. Would love to break those down. But again, facility cost, things that, don't change based off of if there's one patient or 100 patients. Those are the kind of things that go into equally shared. Things that can change from the amount of work, maybe it's billing cost or maybe it's supply cost. Those kind of things are oftentimes in that pro rata bucket. Like, hey, as the more you consume, the more you share it. And then direct expenses. Hey, maybe your malpractice or your CME, or you want to have a specific scribe for you, and when a counterpart is comfortable using the AI scribe, and things like that would be kind of that third category, those direct expenses.
Yeah, I would just say, so many practices, as expenses add on, they forget, right? They forget about allocating those expenses, or they just try to ignore a bit, put it onto the side. And I think those can get really, over your skis when you see, oh, well, you're using so much of the resources in the practice, but we're not accounting for it. The dollars and cents don't line up anymore, for sure.
Yeah. So here's a really, and that's so true. Here's an example of just, hey, so in this example, this is assuming that all the revenue is being attributed to owner doctors. Here, this example, the one physician would have $100,000 attributed to them. They set. Oh,
I think you jumped into the community base. There you go.
This one, okay, they had 100,000 revenues. All the revenues attributed to owners in the group. Again, in the community-based model, that becomes, if you're in a community-based model, well, in an eat what you treat model, like, again, you're kind of assuming that most of the revenue is generated by owners. And here, so that then you'd have the different categories of expenses. So you see they shared equally, then the pro rata, then the direct expense. So the comp is literally what's left over. One of the benefits of the eat what you treat model is it inherently has viability in the business, because the physician, if the physician is paid at the bottom, it kind of follows the Simon Sinek book, the eat last method. So if it's 2 or 3 doctors and they're going to do, build their patient panels, direct primary care practices, I think they really fall into this naturally. The eat what you treat just really can work very well. But again, when revenue is generated by others, the eat what you treat begins to break down. So on the community-based model, when does this work really well? When a significant portion of revenue, again, is generated by non-owners, it's almost becoming untenable to have the eat what you treat model if over 50% of the revenue is generated from non-owners and you have multiple owners. It gets really clunky in there. Also, you do not want to be confined with equal ownership. I mean, we're seeing more and more groups where the senior physicians, it's not a one-to-one buy sell, right? So, hey, you have 2 physicians retiring. Well, we're probably going to have 3 or 4 young guys who want to, buy the 2. It seems like the younger physicians do want maybe less risk, looking for more, like the idea of having partners. And depending where location-wise, sometimes they may be partners not even in the same office. They may, depending on the if it's more rural area, you have some of those dynamics. And also, if there's a different work-life balance, like the community-based models, having an FMV for the work that you do really can make. All right, hey, I want to do 3 days a week. Like, I have a story. We have a physician who he most likely would have retired a lot earlier if we did not put a community-based model in place, where he's like, okay, hey, I want to work. Now he's down to working 100 days a year. So where he's getting FMV for his work, and then he still has a distribution based on his ownership percentage. So as his work days went down, his ownership share went down. So it enabled the younger doctors who were working more to buy in over time. But it also helped the younger doctors to be like, hey, we want to keep him around as long as possible, because it definitely helps the whole practice having that revenue. So that when there's different work-life balances, it this works very well. Again, you do have to set, and again, as this can't be, this isn't, it's not emotional. It's just, hey, we got to do it based off of margin. What can the practice afford, and what is fair market value for work that a physician doing as an employee? If they weren't an owner, like what's the comparative practice look like? Now there's so much good data out there that you can really do a lot of data driven decisions on this front. And then excess is on distributions. This is also very telling, because if you're not having distributions, well, your business isn't viable right now, and we gotta figure out what to do to change that so we get distributions. It does, having the two buckets is a really nice function to have inside the business. Again, so here's an example of this from, the 100,000 came in. You just, if fair market value in this scenario, which a lot would go into setting a percentage, this scenario was 40%. All right, the comp from work as an employee would be $40,000. Then there was a quarterly distribution in this scenario of 30,000 based off of ownership. You would add your share of that to your comp, to your earnings as an employee of the group, to get your total package. And then, yeah, the hybrid models, there's some unlimited combos. I'll share a couple examples. Like I've seen groups say, okay, hey, for the individual physician columns, like we really don't want to have anybody feeling like one partner's earning money from another partner. That was really important. So they said, hey, we're going to kind of do for ourselves, for our piece of the pie in this particular group that I'm thinking of, about 30% of the revenue is from physician owners. So they're 30% of the pie, they're doing eat what you treat. The other 70, they're doing the community-based model and they're not in that. So they're just getting distributions as the other 70% generates distributions. Their 30% of revenue between them is on an eat what you treat model. That worked for them. That's what it was. I have other groups where they'll do, hey, we want to kind of normalize compensation more. So we want to base all compensation on a rolling 12-month average. So they'll take the FMV from this example here. One would not have been the prior month. It would have been an average of the prior 12 months. Again, so many cool nuances that you can get into. Really, I feel like that's one of some of the values that we really provide working with the groups. Hey, again, let's figure out what your vision is, and let's figure out how to match the model, to align the model with your vision. All right, the next topic, and this has really been growing in recent years. You have a lot of practices have gone from, hey, one, two doctor groups to now, oh wait, they've wake up and, hey, wait, we have like 6 to 10 providers in our group, and we got like 50 staff. Like, we don't want to deal with all the stuff that goes on with 6 providers and 50 staff. Well, if you're not going to deal with it, you sure got to trust the person who is going to deal with it. And it really helps when the interest of that person is aligned with your interest, as much as possible. So, and again, Matt, I thought you did this, like paid for presence, not performance. Oh, if we don't see that all the time.
Yes, every day.
The participation trophies may be great for our young children. Participation trophies are not productive in a business setting. And raises disconnected from results, limited accountability for overhead profitability, no growth plan. I do the last bullet point, excuse me, I think really goes back to why it's so important to define a vision. If you want, if you're listening to this and you're a physician owner, or if you're an administrator and you're wondering why you're frustrated, a lot can go into, hey, over the next 3, 5, 10 years, do you see a path for how your earnings grow? And if you don't, well, there's definitely a portion of us that really wants to know, okay, hey, if I work hard, I do things, what's the carrot out there for me? Is the only thing a stick that I get fired if I don't do well? That's one way to live. It's really nice to live when there's a carrot too.
Oh, yeah.
I guess we're all bunnies at heart. I don't know, but it's really nice having some carrots out there. So, when we're working with groups, and just even as you're thinking, is like, hey, tie pay to profitability and efficiency. There's a couple things we can look at. We can show you a model of what we've done in places. Incentives, you may have okay, hey, I want to make sure that we're we're on GPO, we're checking the prices that we're paying for medical supplies, and we have a unified purchasing process, and I want to see cost of supplies go down, right? That may be something that's out there, but and then also, or you're saying, hey man, we've had a lot of turnover in our practice. Like man, I just look and I feel like we had 30 people and we lost 10 last year. Well, man, that's 33%. And so maybe that may be the goal. It's like, define again, what is the primary objective for the group over the next year? And then we can do some things, incentivize. These models still assume a base pay for the administrator, but add on a little bit there. One thing that we have seen work very well is when we're willing to say, okay, hey, we're in that group community model. We have compensation from being an employee. That's a cost to the business. And then we have this bucket that's distributions. That's being an owner in the business, is really having the administrator, the CEO's compensation related to that. So, okay, if our distributions go up, you're getting a share of that. Like we'll have examples where, hey, the CEO gets half a share of the distributions for the business. And man, it really has changed some dynamics where even if you have you have 4 physicians and you're the administrator, right? You have 2 of them love you, one of them's kind of disinvolved, and one of them's like, wow, you just cost me $130,000 last year. I can't believe it. You're so expensive. Well, man, oh, I don't want that, but you want to grow your income, but you don't. You're like, oh, I don't want everybody else thinking I'm really expensive. I want him to think that I'm benefiting him, like I'm generating profitability for him. Well, that's where when you can take the owner comp model, say, okay, hey, let's make sure that doctor is paid well for the work that he's doing, and then let's get this distribution side. And then you, as the administrator in that scenario, like, okay, hey, what do we need to do to meet the needs of our community? How do I service my staff, the staff of the group, so that we can grow distributions for the business? So then if it's like, hey, my compensation grew, but it grew and all the owners comp grew. I've just seen it make it really creates harmonious meetings, and then they're really getting into problem solving, because it's like there's so much limited time to meet, and there's with how we're implementing AI in groups, how we're monitoring the needs in our community, how we're monitoring providers and life and babies and all the things that go on, life events. It's like, man, we need to be using those times we're gathering to work on the business to really solve problems that affect the overall growth and health of the business, not just how we split the pie. So again, I feel like this stuff is so helpful there.
Yeah.
So in summary, define your practice vision, and then align it right down. Okay, hey, we're choosing this model because we believe it promotes our practice vision in this way. Work on your nuances, and then really get into, okay, our non-owner leadership. Is their comp tied to profit, and really, things I like to look at is particular bonuses for building in succession plans for key individuals. Like one administrator did a really good job of, okay, their physicians are there's 3 generations. So there's 60, 50, 40. Actually, this one has 4 generations: 60, 50, 40, and now in the 30s. So that practice has a high opportunity for ongoing succession plans, because okay, as retiring, they can bring on. Well, that was a real win for the administrator to kind of make that happen. All right, so next steps for all. Thank you guys so much for attending. Hopefully this was valuable. You have a recording for this. We're going to send you a summary. in 2 weeks, we have a workshop. Now, again, this was a lot of me talking. And if you're anything like my kids, they've had enough of that. But we would really like to, okay, we would, getting a group of 6 to 8, Matt, you tell me exactly how many it is. We would love to really get into your situation, your scenarios, and talk through your questions as it relates to this, as a next step of, okay, hey, how can you take this to the next step? Hopefully you found this valuable. So enjoyed being here today. Matt, I'll pass it back to you.
Thank you, Gene, so much. Your wisdom is definitely appreciated, especially in these changing times. So, as Gene mentioned, every month we have our Simplifying the Business of Medicine series, which is a blog, this webinar, and then a workshop. The workshop does have limited seats. We are aiming for 10 to 15 people to attend those workshops. It'll be in 2 weeks on Wednesday. So first come, first serve. As a live viewer of this webinar, you're able to sign up first. So if you are a physician owner who is looking to really take your practice to the next level, we encourage you to join that workshop and talk through some of those challenges that you're having. But every month, please let us know what other topics you guys want to talk about. But we have a great schedule for 2026. And every month we have a different topic with the blog, the webinar, and a workshop. And we look forward to helping you simplify the business of medicine. Thank you so much and have a great rest of the day.